So welcome to everyone who's in the room with us today and everyone on Facebook as well. It's really lovely to see you all. Welcome to Professor Jones we've got with us today. We haven't seen you for a while, so it's really nice for you to be back and see you again. How are you?
I'm very well. And apologies for being a little bit late. My computer, I was just telling Mo, my computer decided to update itself at 1 minute to 2, like it always does. The reason I've not been around is I had my knee replaced 6 weeks ago. So for those in the audience who've had their knee replaced or know somebody who has, you know what that entails, which is interesting. And the extent to which your entire value as a human being is defined by physiotherapists in terms of how far you can flex your knee. So I'm going through all of that. So that's the reason I've not been around. But it's very nice because I'm now got less pain than I had beforehand, which is for me is pretty good for 6 weeks. So that's my excuse for.
This is a good one. Yes, we'll let you. Yeah, that's good. Yeah, thank you so much. It's really nice to have you back. So our first question up today has got a few. I hope you've got your document open because it's got a few tricky pronunciations of medication that might push me over the edge already today. So yeah. We have a 73-year-old patient who's had a stent and their hepatologist has taken them off statins. And the statin that they don't want them on is atorvastatin, 40 grams, and has given them bezafibrate instead, but this hasn't done the trick. So the question is there any reason why people with PBC cannot have this statin? And there's also the mention of a couple of alternatives as well that's been suggested, and the patient would appreciate your thoughts on it.
Yeah, and presumably by this, and hello to Louisiana. So it's always nice I love it when we hear from people right around the world. I think I've been to about 25 states in America, including Louisiana. So, yes. Okay. So this is a really important question. I will assume when we talk about stent, that's a cardiac stent. So, stent is a technical term for a tube that you use to keep open a tube in the body. Okay. So we use them actually in bile ducts, for example, after people have had bile duct surgery, but they're also used in coronary arteries to keep the coronary arteries open. And for a variety of reasons, I seem to have been reminiscing a lot in the last couple of weeks about, years in medicine. So I know it's difficult to believe, but I'm 61 this year. Please nobody comment on that. So I'm talking about how our world has changed from when I started as a doctor, and one of the extraordinary changes has been around heart disease and the way in which it doesn't impact on people in the way it used to do. So when I started as a junior doctor, you'd see people in their 30s and 40s having massive heart attacks, and now you just don't see that. And when people do have a heart attack, they go straight in and open the arteries up and they leave what's called a stent in. So stent technology has been a real advance in medicine. Now, you have a stent put in a coronary artery because you've got coronary artery disease. That is pretty obvious. And so therefore, you don't do that unless there is a significant risk or has been a significant injury. So the moment you've got a coronary the moment you've got a coronary artery stent in, you kind of have a certain level of heart disease risk almost by definition. Now, a stent on its own is part of the solution, but it's not the whole solution. And there are two other bits to the solution, one of which is to, in some instances, take tablets or medicines to stop blood clots from forming. So this gets quite complex because it's to do with which type of stent people have put in, but often people need a drug like aspirin or one called clopidogrel as a therapy to keep it open, and that's pretty standard and that's pretty normal. But the other, of course, is that by definition somebody who's needed a stent has atherosclerosis, which is the technical name for the sort of coronary artery disease that people get. So by definition, somebody has heart disease risk, because otherwise you wouldn't have needed a stent. And there are things you can do to reduce the risk of getting coronary artery disease again, either in the arteries that haven't got a stent in them, or alternatively in the other arteries in the body, like the leg arteries or the neck arteries, for stroke and things like that. So you need to manage cardiac risk. Now, there are things that individuals can do to reduce their cardiac risk, like not smoking or managing diabetes properly, if that's that. There are some things that you can't really do, which is to change your family history. But one of the things that's really important is effective cholesterol management, and this is where statins come in. Now, statins do two things. One is they reduce your cholesterol level. So it doesn't matter what your cholesterol level is, take a statin, it will be lower, and lower is better for cholesterol. But they will do something else, which is they will actually protect your arteries. So statins have a very particular action to protect the arteries as well as reducing cholesterol. So somebody who's had a stent or has had a heart attack or has had a stroke, you'll use cholesterol lowering drugs in the forms of statins because you'll have that dual action. And they have been part of this revolution in cardiac disease. Now, bezafibrate is something we're all very familiar with in PBC, and it's an old-fashioned cholesterol-lowering drug. It was used long before statins were invented, and it will also lower cholesterol, probably not as effectively as statins. And it actually has this slightly unusual effect on improving PBC and improving PBC itch, which interestingly statins don't have. So statins have no effect one way or the other on PBC. Bezafibrate does. Statins will lower cholesterol and protect your heart. Bezafibrate will lower cholesterol to a degree, but it has no heart protecting effect at all. So to get round to actually answering the question, somebody with a significant cardiac risk, all things being equal for me, and if you've got a stent in situ, you've got a cardiac risk. For me, I would always be on a statin in that situation. And to go down the bezafibrate route is probably the wrong one. Okay. Now, there might be other reasons why you'd move away from a statin towards bezafibrate, but that says to me probably statin. Now, what about statin plus bezafibrate if you want statin for heart disease protection and bezafibrate for PBC? We tend to stay away from that. We tend to use statin plus OCA in combination because some pharmacists are very concerned and some are not concerned about the combination of bezafibrate statin. It's quite difficult to get a straight answer about it. We have treated a number of people with a combination of a statin and bezafibrate and haven't seen any problems, but some people are very cautious about it. So we would tend to suggest if you need a statin, have a statin, and if you need second-line therapy to control PBC, we would tend to go to OCA plus statin rather than bezafibrate covering both of them, because at the end of the day, bezafibrate doesn't protect your arteries, and if you've got a stent in situ, you need to protect your arteries. I hope that makes sense. So yeah. Sometimes go for the compromise with bezafibrate, just probably not here.
Okay, that's great. Thank you for that. I was so excited to see you earlier that I forgot to do a little disclaimer at the beginning, so I'm just going to take a minute to do that now, okay? So just remember, everyone, these Q&As don't take the place of a consultation with your own clinician. We aim not to provide medical advice, but to provide general medical information. And also just be aware, Facebook's public place as well, but you can join us here in the privacy of the room as well with Professor Jones and I.
And, you know, one of the reasons why I'll hopefully never be replaced by a computer, probably you wish I was, is that it is these nuances. So it is that everybody is different, and so we individualize the information and the guidance we give. And of course, what we don't have in these sorts of sessions is all of the information. So that's why I use things like all things being equal, or, you know, usually in this situation. And that's kind of my starter for 10. So if somebody phoned me in the middle of the night, you know, and asked me a question as a consultant on call, what would you think about this? That's where my starting point would be. But I would then adjust that according to the individual situation. So hence we will often, you know, talk about things, but there'll be something about, you know, somebody might have had an allergy to statins or something like that, in which case it's just on that note, just one thing that is worth saying is that a lot of doctors worry that statins cause liver injury. So frequently, not so much with PBC, more with NASH really, but people will say, oh, we can't have a statin because you've got liver abnormality and statins cause liver abnormality. I can tell you now, I have never seen liver problems with a statin ever. Okay. ever convincingly. Yes, people might have slight liver abnormality, but that's usually the reason why you're using the statin, not the statin. So, I mean, I think there are occasional cases. People like my NASH colleagues have seen one or two, but out of thousands and thousands of people. So that's the one thing I'm not that worried about, which is liver injury from a statin. If you need a statin, they're good drugs. But most of all, literally nobody on this call will smoke. I know that for a fact. I can read into the computer that nobody smokes. So therefore, there's no need for me to say, please don't smoke, because none of you smoke. So I've looked into the computer. But should you ever encounter somebody with PBC who does smoke, please stop. It really, 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 really is bad for you. It's bad for your heart, bad for your lungs, bad for your brain, and bad for your bones.
Next question's about FibroScans. So how accurate is a FibroScan when you're overweight? Previously saw the doctor and they said the score was 7.9 and it showed fibrosis. Doctor recently saw for a second opinion, indicated the score was probably skewed due to weight and he wasn't too concerned. Should I get a biopsy to know for sure? So it might just be good just to talk about the FibroScan scores in general, just to understand, you know, the levels.
Okay. So there are always two aspects that we look at with PBC. Think of it as a graph with an x-axis and a y-axis. And one of those is how active the disease is, how much inflammation is there in the liver right now. And that we largely determine by blood tests. So that's your ALP-FOS test in the clinic and some of the other blood tests. So that's saying how much inflammation is there, how much injury is going on right now. And then the other element is how much scarring is there in the liver, which is how much injury has happened in the past. Okay, so it's backward looking, but what's the cumulative injury that's happened in the past? And those are very different things if you think about it. So, and obviously, if you've just been diagnosed with PBC, you may have no scarring at all. So that will be fine, but you'll have quite active disease because you're not on any treatment. We actually see, you know, sometimes people with cirrhosis, you've got a lot of previous damage, but the disease has just gone completely. So you do need to look at both. And of course, in the old days, we used to look for scarring using liver biopsies. So that was something that used to be done. But liver biopsies are not that useful in PBC. People don't like them for entirely reasonable reasons, but they're also not that useful because the disease is quite patchy. So you can have everything from normal liver to stage 4 cirrhosis in the same liver. There are plenty of research studies that have shown that. So if you get a biopsy that shows stage 1 disease, is it stage 1 everywhere, or is it just stage 1 and the bit you biopsied and it's stage 4 somewhere else? So biopsies are kind of not that useful because the analogy I always use is it's like plucking one person, because it's tiny, biopsies are a tiny amount of the liver. It's like plucking one person in the football crowd at St. James's Park in Newcastle out of the crowd and asking if they're representative of the whole crowd. Now, they could be an overweight Geordie who's drunk too much beer and his shirt's taken off in the snow, because that's about 98% of the people in the crowd. But it could be a grandmother taking her children to the football for a birthday treat, in which case that's entirely not representative, but you've just sampled that person. So that's the difficulty. Now, FibroScan is a really clever technology, but it's not an infallible technology. So it's a clever technology that relies on sonar like they use to detect submarines. So it sends a ping out, it's like an ultrasound machine, sends out a ping, and it measures how much of the ping comes back, basically. And rather than making a picture, it measures the amount of the ping. And the more solid something is, the more of the ping comes back. You know, it's like if you want to hear if a train's coming, you put your ear on the rail, because solid transmits sound better than air does or fluid does. So that's the principle behind it. So it doesn't actually measure fibrosis at all. It just measures how solid the liver is. And that's important because although mostly solidity in the liver comes from fibrosis or scarring, it isn't entirely that. And that's important to be aware of. So a lot of people talk about how much fibrosis you've got based on FibroScan. No, there is no measure of fibrosis. It is measure of how solid the liver is. over 1,000 people in a population, if you did all 1,000 and did the measurements, on average, it would be very accurate. But like lots and lots of things, the closer you get to an individual, the more the danger is it's not accurate, because, you know, other factors, and there are factors at both, what are called at both ends of the probe. So one factor is how experienced and confident the person doing it is. And then the other is, are there any other things going in that may just going into the equation that might disturb how much of the ping is returned? And that might include, you know, whether there's some lung between the liver and the chest wall. That happens in some people. It could be fat. It could be what you had for breakfast. So there are other factors that can impact it. So so it's not infallible. Over 1,000 people, those will even out. For a single person, they won't necessarily do it. Anybody who looks at a lot of FibroScan values will tell you that you see rogue results. You just do. Okay. You have somebody who has a good result, a good result, a good result, bad result, and then everyone goes, oh, the disease has progressed. Well, actually, you do it again, it's a good result. And it's difficult to explain that other than these things just happen. It's an observer error. One of the issues with FibroScan is that there is no hard copy of it. So it is a real-time test. It's like watching somebody walking down the street and then trying to describe that person. You can describe it, but you can't go back and repeat it because it was a moment in time. So it's not like a CT scan, or, for example, or an MRI, where there is a hard copy that we can go back and look at. So at the end of the day, somebody did it and they got a certain value. And, you know, is that a true reflection of how much fibrosis is in the liver? Well, it could be, but it also possibly may not be. And therefore, you have to contextualize it always. Now, what do the numbers mean? Normal livers are around 4 to 6. Your liver has a certain solidity to it, without which it would fall apart. So 4 to 6 is normal. Somebody who is starting to develop scarring in their liver that we would be worried about, we're going, don't like this, would be in the sort of 10 to 12 range. So that's the point at which we're starting to be a little bit concerned. And the French Christophe Corpus, who's done a lot of work in this area, has very nice data showing that actually literally 11 is the value where you start to be a bit worried about it. And cirrhosis is probably around 17 to 18, something of that order. Okay, so those are the ranges. 4 to 6 is normal. 10 to 11 is starting to be worrying. 17, 18 is cirrhosis, right? Now, PBC does not change rapidly. So if you have a FibroScan done and have one done 6 weeks later and it's gone from 5 to 25, no, it hasn't. The disease doesn't work like that. So you've kind of got to look at whether this makes sense or not. Somebody with a FibroScan of 7.9, I'd never be worried about, actually, because that's fine. So that is typical for somebody with PBC. It's very rarely completely normal because you're always going to have because you get a little bit of bile retention in the liver always, and that causes the liver to swell a little bit. That's why you get that's why you get the pain in the right side of your tummy. The liver's a little bit swollen. When it's swollen, it's a little bit more solid. So FibroScan of 7, if I was confident in that, I would absolutely not be concerned with it at all. Fat in the liver is a challenge, but it's one where the modern scanners are much better able to look at. So they now have a second way of looking at it, which is called CAP, which allows them to measure how much fat there is in the liver. So actually that should be routinely done. So the days of not really being able to interpret a FibroScan in somebody who is overweight are pretty much gone. So the only thing that might happen is they might just not be able to get a value. So if somebody was really overweight, they might not be able to get a value at all, at which point they've got no value and you can't use any information from it. But if they've got a value, if they're reporting a value of 7.9, then it's going to be around about 7.9, in which case I wouldn't be remotely worried. And I absolutely wouldn't have a liver biopsy in that situation. So the plea, if you like, is to to treat FibroScan is a really useful additional bit of information that avoids us having to do biopsies in lots and lots of people. It is not, however, the holy writ of God handed down on a tablet of stone. You have to take it in context. So I use it all the time. We have it in our clinic. We use it all the time. I use it mainly to reassure people, actually, in people who've got really well controlled disease, but we do not overreact if you get a high value. We check it, we do it again on a different day, potentially with a different person doing it. So if somebody does have a very high value, the answer is don't panic. What I always say to people is, frequently people get a blood test done and it will show a potassium value of 10. Okay, that's normally 3.5 to 5. And a very high potassium value potentially has cardiac risks, but it's not possible to be alive and have a potassium of 10. What's happened is that the red cells have broken down when they took the blood sample and some potassium has leaked out. So junior doctors who are new to all of this will start panicking, get potassium of 10, gets phoned to the ward, really high value, they'll panic, start speak to the renal doctors to get dialysis. And the answer is you just need to repeat the test and it always comes back normal. So it's not regarding tests as an infallible marker of what's going in, but regarding them as part of the picture. So FibroScan is really useful, but I've also seen people who've been scared by it and had people have unnecessary investigations on the back of it, when in fact, step back, deep breath, repeat it, and then you find these anomalies tend to disappear. So great. 95% of the time it's brilliant, but you just have to remember there's a 5% where it just throws curveballs. But 7.9, don't have a biopsy.
That's great, thank you. We have another question now. Someone who's asking, their mum has had PBC for 32 years. She keeps well on Urso, but does now have cirrhosis and multiple grade 2 varices. Following a recent endoscopy and CT colonoscopy, they are thinking of banding the varices. She's never had a bleed, but they're considering this as a precaution. She has red wales on report. Would you have any advice on this, and should we be concerned? She already takes medication for hypertension. Her mum also has rheumatoid arthritis and Parkinson's, but again, keeps really well considering.
Okay, so that's a really good question. It brings a few things out that we actually haven't talked about very much in these sessions. So I talked about the two dimensions, one of which is how active the disease is with the blood test, and the other is how much scarring has happened prior to that. There is in fact a third dimension to all of this, which is time. Okay, which is time. So when you've had PBC for a very long time, then it's almost impossible to completely control it. Okay, so there's some work now come out which is very interesting, which looks at not how high the ALP phos level is, but what you might call the area under the curve. So if you plotted alkaline phosphatase every week for a year, it's actually what's the space under that line? How big is that space rather than any one individual value? So 52 weeks at an ALP phos of 150 is actually worse for you than a value of 250 if that value for 250 was there for a week. Okay, so it's the total length of time. And of course, the longer you have it, the more difficult it is to control completely. Okay, so you've got to control it every day of the week for every week of the year for 32 years, and that's quite difficult. So one reason why people get cirrhosis is because they've got very aggressive disease. Another reason might be because it's not been treated properly, and the third is you've just had it for a very long time. And often, when people come along and say, but I thought my disease was well controlled, why I've got cirrhosis, I actually talk about the 30-year rule, that it's actually quite difficult to have PBC for over 30 years and not be at risk of getting that. So that rather nicely fits into this. And this is one of the reasons why we focus on younger patients so much, because obviously, with the best will in the world, if you're diagnosed at 80, you're probably not going to have PBC for 30 years unless you're going to get into the Guinness Book of Records. But if you get PBC at 20, you are. And so therefore, that's why we place so much attention to good control in younger patients. So what are varices? Varices are where you get blood vessels at the base of the gullet. They're because the pressure goes up in the blood vessels around the liver, and that's a feature of cirrhosis, okay? And the good news is you've not had a bleed. And in fact, most PBC patients don't get varices, and most PBC patients who do get varices don't get a bleed. We haven't had a bleed in any of our patients for a number of years. Why is that? Because we control the disease much more. But you will get people who present late, and you will get people who've had it for 30 years, and the 30 years rule. So, pros and cons. So, if you've got grade 2 varices, they're there. And clearly, if they're there, the chances of bleeding from them are higher than if they weren't there, because you can't bleed from them if they're not there. And so, not having a bleed is something that you really want to do. If you can possibly avoid it. There are two ways you can prevent a bleed. One of them is through tablets and medicines, through some of the beta blockers that are also used for heart disease. And the other one is through what's called banding, where you basically block the vessels off during a telescope test. Now, banding is a really effective treatment. So if you had a bleed, that's what they would do. Okay, so if you had a bleed, they'd do a telescope test and they'd band and block the vessels off like that. And my endoscopy colleagues, I'm not an endoscopist, but my endoscopy colleagues are very good at it. And it's a really it sounds terrible, but it's a very non-invasive thing, and it's really effective. Would you band somebody who's got varices but has never had a bleed? Okay, and that's, you're more into 6 and 2/3 territory. Okay, and if you want to take a particularly scientific way of looking at it, it's like playing pontoon, and do you stick or twist on 16? Okay, and the answer is some people will and some people won't. Some people, it's a risk-benefit thing. If somebody's had PBC for 32 years, it implies that they're moderately advanced in years. People don't tolerate bleeds well, the older they get. And all things being equal, I'm going to use that again. If a good skilled endoscopist thinks banding them's the right thing to do, banding them's probably the right thing to do. Okay, because what they will have done is have weighed up what's the risk of banding versus what's the risk of having a bleed. If you've got heart disease, you've got a heart that may not be able to cope with a bleed quite as well. So it may well be more harmful to you. So my colleagues who look at these things, look at their, what I call bandability, how likely is this to be effective? And they look at what the downside might be of having a bleed, and they look at how likely you are to do well with it. And if they think you should be banded with confidence. It's a really effective intervention. And if you're in your 70s, for example, you really don't want a variceal bleed, I would have banding, elective planned thing. Think of, you never want to have a burglary, and the chances are you're not going to have a burglary, but burglaries are pretty horrible. So therefore you have insurance. And did I need the insurance? The truth is you'll never know. But you get banded, you don't have a bleed, you'll never know whether it stopped a bleed, but you've not had a bleed, and that's all you want, really. So just basically you want to avoid a bleed if you can. So that sounds very reasonable to me. And the fact you got cirrhosis after 32 years is the challenge of, getting it right all of this time for all of those years. And I think increasingly, and obviously, it kind of is obvious that if somebody's had PBC for 32 years, you're looking at the treatments initially of 32 years ago. And of course, nowadays, people presenting with PBC are treated in a very different way. We have much more in the way of treatment. So in a way, hopefully this problem will disappear, because it is more possible to get complete control. But it is the reason why we're looking towards normal liver blood tests as the target of treatment, because almost certainly, even a significant reduction in the blood tests, if they're still abnormal, and you lose sort of 5% of your liver, after a year, well, you've still got 95% of the liver. That's not too bad. But next year it's 95% of 95%, and then it's 95 of 95 and 95. So probably the more we go for complete control early on, the more the 30-year rule won't apply. But it sounds reasonable to me, very individual. It's how badly you don't want to bleed. And if you don't really, really badly don't want to bleed because you've got heart disease, banding is the way to go.
Mm-hmm. There was mention in the question as well. She just mentioned that her mum has a degree of pain but limited to what she can take due to PBC. She may qualify for medicinal CBD due to Parkinson's. Would this be detrimental to her liver?
Medicinal CBD. I laughed because a couple of years ago, George Mells, who many people here know, George has the brain the size of a planet. Okay, George talks about things, and I agree with him because I don't understand, because he's cleverer than me. But he did a really interesting study with colleagues to take everything we know about the genes of PBC, which give us clues as to what's going on, and they discovered a database that showed us every single drug there is and how they're thought to work and how they might overlap. So we've got the genes that tell us what might be happening in people with PBC, and then you take all of the drugs we know about in the world and you look at whether they affect that pathway, and you put the two together, and from that you come up with a list of drugs that ought to work in PBC, right? And you also come up with a list of drugs that ought not to work in PBC, for example. And it's really interesting because when you do that, the Americans did a trial of a drug called abatacept a number of years ago, and it took 5 years, and there were quite a lot of side effects, and it showed absolutely no benefit whatsoever. But George's computer technique would have told them in 30 minutes it wouldn't work, which I thought was quite interesting. So it also shows some slightly surprising drugs. So, for example, drugs called retinoids, vitamin A, related to vitamin A, which are also used for acne and things like that. So they're used in a number of situations. They're a particular class of drugs, and they would theoretically work really well in PBC. Nobody's ever looked at them or done a trial of them. And of course, interestingly, PBC patients are often a little bit short on vitamin A. So it's just interesting, isn't it, that it kind of makes a little bit of sense. So it's a really clever technique. And it does throw up some really interesting potential drugs. So why am I whittering on about all of this? Well, one of the drugs that came up in George's screen was CBD. Okay. So not only is there no evidence that it's harmful in PBC at all, and we have a number of people who've used it, and we happily discuss that with people. There's no trials, but it's been used by sensible people. But there is a theoretical benefit from it. And so it's just really interesting, because what this approach is, the danger with drugs is that we just trust the things we think of, okay? And it's the things that work in a completely different way that we haven't thought of. So we're limited by what we think we know. And if you then do it in what we call an agnostic way. So it's a really interesting potential approach. But CBD comes up in that, as interestingly does metformin. Now, metformin is a drug that many people with type 2 diabetes, common in the population, take it. We very rarely see people with PBC, our patients on metformin. We rarely see people taking it. It's very interesting. Have they all had their PBC sorted out? I don't know. Doesn't replace clinical trials, right? This is 2 + 2, normally it's 4, right? But you've got to do it. It doesn't replace clinical trials. What it does do is suggest where you should perhaps look. So it is an interesting way to guide how to go ahead. And interestingly, we've just done it for PSC, so people are very familiar with primary sclerosing cholangitis, which is a very complicated condition. But unlike PBC, it has literally no treatments. With PBC, we're in the very fortunate position where we've got a couple of licensed therapies. We've got therapies that work. We've got therapies about to be licensed. We've got, as we found out through the foundation and the summit, a really exciting pipeline of new treatments. So we're not short of treatments. What we need to do is to work out how to use them to the best advantage. But PSC has no treatments, and they don't know what to do next. So we've run this technique, and we've highlighted the drugs that they should be looking at. So I think it may be more useful in that situation than in PBC, where we've already got a lot of progress, where it's a bit of a heart sink condition. So it identifies some treatment. Interestingly, they're very different to the PBC one. So many ways the disease is the same, but actually when it comes down to this approach, it's very different. So CBD, yes, George Mells showed, using his brain the size of a planet study approach, that it's potentially beneficial.
Sounds good. Thank you for that. I'm just going to flip and take a question in the room here. So we've got a patient who's recently diagnosed with PBC, had bloods done a week ago. Results are stable since the last blood 7 months ago. Is this good? They've been on URSO for 4 weeks now. So I suppose it's just around what to expect in the first few months when you start URSO after diagnosis.
Yes. So PBC is a condition that changes only slowly. Generally, it's not a condition that has big ups and downs. So if this was autoimmune hepatitis, for example, which many people have heard of, which is a really inflammatory immune condition in the liver, you can have tests that change in the space of a week. PBC doesn't behave like that. With URSO, the other thing is that URSO takes time to get into the system. So if you take URSO tablets, it will take you 3 months really for them to get into the system. The reason for that is they have to get enriched in the bile. So there are lots and lots of cycles of it going through the bowel, being taken up, going out in the bile, and round it goes, and it gets enriched slowly. Okay, so it's a concentration. It's like well, we could say this for Scotland, can't we? It's like distilling fine whiskey. Triple distilled whiskey is nicer than double distilled, which is nicer than single, because it goes around this concentration of the flavors. So do you like what I did, the Scottish thing? You like that? So it takes a little while. So the bottom line is, when somebody starts URSO, you would start to see some benefit, but it would ramp up over basically about 3 months. And probably from 3 months onwards, you wouldn't see much change after that. So you've seen what you're going to get by about 3 months. Now, interestingly, bezafibrate, betacolic acid, elafibranor, seladelpar are much faster working. So they're all the second line treatments which are now available, or we suspect going to become available. They will work in weeks, not months. So they do not have to get into the system. They have an active effect, and you will get an effect within 7 days on those. And I think this is interesting, because one of the things I think, going back to the 30-year rule, and that area under the curve, is that you want to have the most number of days you possibly can in your life at the lowest level of abnormality of the tests. Ideally, completely normal tests forever, right? Mm-hmm. So this kind of waiting around, giving it 3 months to see what the effect is with URSO, that doesn't really fit with that model. It's not helpful. So actually, one of the things that's probably a negative about URSO is it just takes time to work. And I think we all think about the newer therapies being more effective, which they are, but they're also faster in their action. And if this number of days that are abnormal per year is important, that might be an important thing. So speed of action. So URSO, we tend to measure again at 3 months after people have started it. We tend to give them a phone call, check they're okay taking it, and then we measure the blood tests at 3 months, and it gives us a sense of where we're going. And then we book them in for a 1-year review, because it's the blood tests at 1 year that dictate where we go next with it. Mm-hmm. But remember, if newly diagnosed with PBC in this day and age, we want normal. Okay, only normal is normal. I think is the mantra increasing. It's easier for us to understand, easier for you to understand. The concept of acceptable levels of abnormality, I'm not sure I understand that. This area under the curve thing, everything points to normal. Okay, so anybody being diagnosed now, if it's 32 years ago, that's water under the bridge. If you're being diagnosed now, complete control is what we're looking for.
I think I'm just picking up another question that's came in the room in here, but I think actually you've already mentioned some stuff about that, just as you were talking about the last answer there. Just someone was a bit disheartened initially by the comments regarding the 30-year rule and disease progression, but then you went on to quantify that afterwards, talking about the new therapies. Yes. And you've touched on them there just now, but I just wondered if it was worth going into them in a wee bit more detail about the new therapies that are coming along.
Yes, so the world has changed out of all recognition in PBC, okay? So it's changed in 2 ways. It changed twice, okay? So the first was the advent of URSO, and the second is the advent of second-line therapy. And I predict it will change again, and we'll explain why. So before Urso, we had no therapy that worked. And so essentially you watch people for disease progression and complications like the varices we've talked about. Then Urso came along, and Urso was a little bit perhaps oversold. So Urso clearly has a benefit, clearly improves the blood test, but it is not the absolute answer in PBC. It's part of the answer. It's a gentle first treatment, and it's most people need, majority of people, but a significant minority of people, it's not enough, right? And I think the realization of that and the development of alternative therapies to go with it was the second big revolution. And that started with the drug called obeticholic acid that people are familiar with, Ocaliva. It also happened with bezafibrate and fenofibrate. And actually, of course, ironically, they were there long before obeticholic acid was. We were using fibrates 20 years ago in PBC. And there are plenty of people where we treated them 20 years ago and they're absolutely fine with normal liver blood tests. We've known that for a long time. And then, of course, you've got two new drugs, brand new, called elafibranor and seladelpar, which are just going through the approvals process now. And they work in a slightly different way to obeticholic acid. They work in a similar way to bezafibrate, probably more effective and probably less in the way of side effects. They're all very effective at improving the liver blood tests, and we think they're very effective at preventing scarring in the liver and preventing progression of the disease. Okay. Where we are right now, the most effective combination we have is triple therapy. It is Urso plus obeticholic acid plus bezafibrate. 80% of people on that have totally normal liver blood tests, and that's effective, right? You know, most of the others, it's below 50% normal. You know, in terms of a response, much higher than that, but in terms of normal, which we're looking for. So, you know, that's probably in pole position at the moment. And it's no coincidence that that's probably the commonest combination of treatments we now use in people needing augmented therapy. So put all this together, we should be using better therapies earlier in more people, for me. You know, in a sense, it's a slightly odd thing for clinicians to look in detail at why we don't use effective therapies. An odd thing about PBC, which is we should be looking at complete control and then working backwards to scale it down when you don't need it. But we ended up with a model where you tentatively increase the therapy. So I think people, you know, there's a comment here about being diagnosed in the 50s and you're wanting 30 years of reasonable quality of life. Absolutely correct. But of course, the difference between this and the lady who, you know, was at 32 years is that you know, in 32 years ago, in, you know, what, 1990, we only just had Urso. I didn't have any of these second line therapies. I mean, we certainly in Newcastle weren't using fibrate. So there's a big time lag with it. But what's going to come out in the wash is targeting normalization, this realization that actually it's really effective therapies. And why mess around, you know, rechecking and start other things? Why don't you just start the right treatment and then perhaps, you know, a year down the line, see if you can drop that down. So do it the other way around. With all of this, I think the next stage, so the next big revolution, if you like, is normalization as the target. But after that, it's going to be, why wait a year to see what Urso does? Why not actually just start, you know, the combination of treatments at the beginning? I mean, why not just do that? Why make it complicated and do it simpler? We're actually doing a trial in the UK called Opera, which is open, I think, in 6 or 7 centres across the UK now, which is to do precisely this, which is newly diagnosed people with PBC who are unlikely to go normal with Urso, are now being offered the combination of Urso plus obeticholic acid right at the very beginning, with a view to normalising their test. So it's immediate use of more effective therapy and normalisation of the target. And we started this about, you know, this journey about 3 or 4 years ago, but now it's absolutely mainstream thinking. It's absolutely the way this is all going. And I think this will also happen with the new therapies. So I think if you are in your 50s, newly diagnosed with PBC, it's earlier, better, and totally effective therapy. So don't rest until your blood tests are normal, taking whatever treatment you want and need. And I think Mystic Meg, I think the real value of elafibranor and seladelpar will be, I think they're going to be really good drugs to use really early. And I think that's where they're going to come in. I think obeticholic acid is the big guns in terms of the actual disease process. And so I think it's always going to have a role, but I think these are the drugs that I might want to use right from the very beginning. And I'll let you into a secret. We're not waiting a year. Okay, but you didn't hear me say that. Because why wait? If you've got an alkaline phosphatase of 1,000 and it's dropped after 3 months to 800, it's not going to get to 200. Okay, so we're starting bezafibrate much earlier and then putting obeticholic acid in afterwards. So I think if I was diagnosed with PBC early, the FibroScan of 5 nowadays in my 50s, I wouldn't be remotely worried about this disease, because there are so many effective treatment options. And the main risk is people not appreciating what needs to be done and what can be done. And I think that there's still a big education thing. We see too many, Mo will agree with this, we see too many people who just don't have the basics done right. And please do not die of not wanting to offend your doctor. Okay, if you are sitting here thinking, I'm not getting this, I am not getting this, I'm not getting this, they're talking about these things, I've alpha 300, I'm not getting this, please do not worry about offending your doctor. Go and ask them why not. Okay, honestly, we can all be too British sometimes, and I didn't want to upset them. If you're not getting what is standard normal therapy, which is what we talk about, nothing here is radical. What we're talking about here is available everywhere in the country. This is all standard therapy. If you're not getting this, go and ask your doctor why not. And frankly, if they won't engage in discussion with it, ask for a referral to a centre that will do it.
Yeah,
okay?
And if anyone needs any assistance with that, please just reach out to us. We can do that. Also, in the Bare Facts last edition, there was the care bundle as well. So that gave lots of information in terms of what's required at each stage, just so that people can have that.
Please,
by all means, take it into your doctor, talk it through with them. But
the Americans, we need to fall in love with our inner American. The Americans do this all the time. If they don't like the care they're getting, they basically say and change doctors, and we need to do more of that.
Yeah, but if anyone's concerned at all and wants to talk it through, please just give us a call on the helpline, and we can do that for you here.
And remember, these drugs are not steroids. They do not have significant side effects. These are really well tolerated. Now, which one you choose will be dictated by lots of different things, but we're going to have probably first-line, Urso as first-line treatment, then 4 highly plausible, highly effective, safe and well-tolerated alternatives that we can use in the right combinations in people. If you'd asked me that when I embarked on this journey, my first PBC clinic in 1991, if I thought we would have 5 really effective therapies, I would have fallen off my seat. So that's why anybody, embarking on this journey should be optimistic. Is these are really good treatments.
When I was first diagnosed, it was just Urso as well. So, I mean, it's such a lot has changed. And do you think it will be, you mentioned there about combination, it won't be a case that there are the opportunities for people to try multiple of these other drugs, isn't there? So
and I think that's the lesson.
Try other things.
If you take a lesson like hypertension, okay, so high blood pressure, they learned a long time ago that lower doses of several drugs in combination was much more effective than high doses of a single treatment. And I'm sure we'll go down exactly the same line, and that you will understand the effects of the different drugs and will use them in combinations. We've seen this, I mean, in hepatitis C, for example, was a very classic example of starting with a single drug that wasn't effective, and then you got a better one, and then you used it earlier, and then you understood who wasn't responding, and then you added more drugs in, and now 95% of people are curable with it. So I think the combination of obeticholic acid with either elafibranor or seladelpar will get normalization over 90%. Okay, so that's the next combination. Okay, and then somebody will put it in a combination pack, so that you take one tablet with both of them in it, and that's what happens. All these things. That's the direction. That's the direction of travel. So I think we'll lose bezafibrate. We'll replace it with the 2 newer ones in combination, and then Bob's your uncle. Then you're as close to complete control as you're going to get.
Which is brilliant, isn't it? Just to see everything
and
that's happening.
Personally, and personally, I think the final frontier is going to be symptoms. And personally, I think if you start really effective treatment very early in the disease, before symptoms develop, you'll prevent symptoms. I think preventing symptoms is going to be much more effective than trying to control them. But that is an opinion, but based on watching this. So I think we sit back and allow symptoms to develop, and I think we should be on the front foot to prevent them.
Great. We're getting close to end of time, but I just wanted to take the opportunity to ask one more question. It's something that I've seen asked before as well, and it's just a patient asking if there's any link between PBC and anemia.
Oh yes. That'll make a very good exam question for doctors, because there are several connections between PBC and anemia. I did medicine in the old days in Oxford, which was a very old-fashioned place. And one of the questions I asked, we had to write essays rather than diagnosing people like you do. And one of the questions they asked is, what was the contribution of Dr. Charcot to medicine? And it was a trick question, because Dr. Charcot described 3 different diseases. So you could be a smarty pants like I was and know that Dr. Charcot described 3 diseases. There's no value whatsoever to treating any patients, but this is a little bit like it. So PBC, so anemia is very important in PBC because it's common and because it will contribute to fatigue in particular. Okay. And actually, there's a theory that iron deficiency can make itch worse. It's an interesting theory. So it will contribute to fatigue. So when we are looking at people with fatigue in our structured approach, then the first step is look for anything that's going on that might make it worse. Okay, your quick wins, thyroid disease, for example, right? Itch at night, keeping you awake and stopping you sleeping. But anemia is absolutely one of those. And there are basically 3 types of anemia that people with PBC get. And of course, there's no reason why you shouldn't get any of the other types. So the 3 things that are associated, the first is celiac disease. So celiac disease, people will be aware of, it's an absorption issue around gluten in the diet. But what it does is damages the ability of the gut to absorb food. And it's particularly certain nutrients that aren't absorbed. So iron deficiency anemia is very common in that. So we always look for celiac disease in PBC patients with either anemia or with fatigue, because it's about 5% of people get it, right? So, and you'll not treat that unless you know it's there and give somebody a gluten-free diet. So anemia because you don't absorb iron because of celiac disease. The second one is a condition called autoimmune hemolytic anemia, okay? Autoimmune hemolytic anemia. And that's where the immune system targets not the bile duct cells like it does in PBC, but it targets the red cells, so it breaks them down. So it's another autoimmune process. And once you've got one autoimmune process, you're at risk of getting others. So it's an autoimmune association. This is pretty rare in PBC, but you will see it every so often. And that's treated by giving people antibody infusion. So it just needs, again, it's specific treatment. And for lovers of obscure facts anywhere, and one day somebody will go on to Who Wants to Be a Millionaire, and this will be their millionaire question. And then please remember, you heard it here first. The small print, really, really arcane thing is that both autoimmune hemolytic anemia and PBC were discovered by the same person, which is Thomas Addison, the famous doctor, and he had no idea that they were in any way, shape or form connected. So it's totally coincidental that they were both described by the same person. So there you go, obscure fact of the day. And then the third one is B12 deficiency. So you get a thing called pernicious anemia, which is where you have an autoimmune process, just like PBC, just like hemolytic anemia, but this time the target cells are the linings of the stomach. And the lining cells in the stomach produce a protein called intrinsic factor that you have to absorb B12 from the diet. So you can eat B12 containing things until you're blue in the face, and you will never absorb them unless your body produces intrinsic factor, because they can't get across the gut wall. So if you don't produce intrinsic factor, you can't absorb B12, so you're B12 deficient. And the autoimmune process destroys that. Now, the treatment for that is not B12 tablets, because if the problem is you can't absorb it, then, triple the amount you take, you still can't absorb it. And that's why people are on 3-monthly B12 injections. None of those is a significant condition. None of those is harmful. None of those is dangerous, but none of those will be treated unless you cotton on to what's going on. So we have a very standardized way that we approach anemia. Now, clearly, anemia in the population is caused by other things you need to be aware of. So the one that people are always concerned about correctly is bowel cancers and diverticular disease, so across the population as a whole. The average 70-year-old developing iron deficiency anemia, you'd need to be concerned that there isn't a cancer causing it. But there are plenty of reasons. In fact, bowel cancer is not very common in our patients, but you will get investigated for those things correctly, because that's a safety first principle type of thing. So don't forget the other common things in the population. They're not associated with PBC, but common things are common, and you need to think about that. But celiac disease, B12 deficiency with hemolytic anemia, and hemolytic anemia are the 3 specific PBC causes. There you go.
Brilliant, thank you. And I just want to echo a thank you that's came in on the room in here as well, as we really do appreciate your time today, but also that you're still recovering as well, but you're here with us still today. And someone just said that in the room there, and I thought that's exactly right. You've taken your time out to be with us today, and we all do really.
I've missed it. I haven't done.
We've missed you.
So I'm like the Energizer Bunny, aren't I? I'm full of energy doing it all. But good questions is great, and I hope that the messaging about the 30-year rule is, remember, the disease presenting now, those 30 years are forward-looking, whereas the disease presenting 30 years ago, I'm afraid it was a different world. And you know, when I first managed PBC in 1991, half the people were jaundiced, and half the people had cirrhosis. Now we have nobody who's jaundiced, and we have less than 5% of people had cirrhosis. So of the things that we do, or the things we talk about here, something works because it has changed out of all recognition. And that's what I sometimes emphasize, perhaps to younger doctors coming in, all of this, you can't see what the problem is. And that's because we've made the problem go away. But we need to make sure the problem stays gone away, if you like. And it's gone away for everybody. And so the challenge changes. It's not developing new treatments now. It's making sure that everybody gets them at the right time, so you get the maximum. So it's attention to detail.
The education as well, isn't it?
It's education. It's being shy bands, getting out, you know, with your doctors, keeping on the toes. And Mo's point, absolutely, is the foundation is here to help with that, to help you to have those conversations and to make sure that happens. So it's all done in the nicest possible way, gentlest possible way, but this is all well understood. This guidance is all out there, so you know there's no reason for doctors not to do it. So just nudge them, and if they really aren't going to be nudged, find a new doctor. Okay, we
all need to be our own advocates, don't we? It's all about having the right information and doing that. So thank you so much. So thank you so much for joining us today.
Absolute pleasure. Until next time.
See you, and we'll see you soon.
Okay. Thanks,
Take care.
everybody.
See you later. Bye.